Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
All right. So I welcome one and all for the class tonight. I hope you can hear my voice clear. And today I'll not be presenting the screen. So one of my students would be the one who's presenting the case tonight. The case is that of prolapse uterus. It's a very big and important and a very confusing topic. But I'll be sticking on to the very basic and important questions, the one which are expected out of you as a postgraduate, the one which is going to make you pass or fail the examination. Of course, you can go very high. You can go to urogynecology and everything, and even talk about the sling surgeries and the stress urinary incontinence and stuff. But tonight we'll be restricting ourselves to prolapse and its various dimensions. All right. And like I said, one of my very sweet students has agreed to take up this task of presenting the case of prolapse. So I welcome one and all. And though I would be expecting more students tonight, but it's a different time and it was last minute that we announced this class. So never mind, the recording will be there on my channel. And I can see the list right now is less of students, as I was expecting more students to join. But I would not be wasting our time and waiting. They'll keep joining in between and we can start the case up front. So I welcome everybody to tonight's class and let's jump on the prolapse case because we have a lot to discuss in the class. I'll be doing one thing, especially after the class, we'll be discussing a lot of stuff. So I would want that everything goes inside the presentation so that everybody, once they are through with the case, they know exactly what to study. And yes, I have posted many of my videos in the channel. I did that deliberately so that everybody gets the hang of how to take and how to measure the to make the grid of POPQ, because that's a very big aspect of your prolapse case presentation. How to do the POPQ grid, correct? What all to be measured in the reduced position, what all to be measured in the prolapse position, how to measure them, and everything I have described in detail, everything in my lectures. Not just only that, even I took a prolapse presentation couple of weeks before, couple of months back, and in that I have described everything right from the physiology, the pathophysiology of uterus to the final management of prolapse. And management of prolapse is not only restricted to just what you always talk about, vaginal hysterectomy and anterior and posterior vaginal wall repair. No, there are a lot of dimensions of prolapse, a lot of stuff which we'll be discussing tonight in the class. So let's begin with the presentation. And everybody, I request everybody who's there in the class to kindly be very active in the chat, because it's not just the presentation of one person alone. I want everybody to participate thoroughly in this class so that we all enjoy. All right. So, okay, we start our case. Nikhil, welcome to the class.
Yes,
and
ma'am.
let's start with your case.
Good evening, everyone. So I'll be presenting uterovaginal prolapse. So Mrs. X, 55 years old lady, wife of Mr. Y, resident of Delhi, belonging to lower socioeconomic status by Kupuswamy scale. A farmer by occupation, she's para 5 L5 postmenopausal lady who came to the OPD with complaint of mass coming out per vaginum since 1.5 years. Patient complained of mass per vaginum since last 1.5 years. It was gradually progressive in size. The mass increased in size on cuffing, straining, and lifting heavy weight. The mass reduced
Sorry to
spontaneously.
disturb you. Please also change your slide. What we can see is the previous slide. Yeah. Keep
Ma'am, is it
changing your slides
visible?
also. Yeah.
Yes, ma'am, I have changed, ma'am.
Okay, I could not see the slide.
Ma'am, is it visible? My current slide is visible.
Yeah, it's visible.
So, patient complained of mass per vaginum since 1.5 years. It was gradually progressive in size and increased on cuffing, straining, and lifting heavy weight, and reduced spontaneously on lying down. It was associated with heaviness, dragging sensation, and feeling of pressure and difficulty in walking. She gives history of manually repositioning the mass while passing urine, along with a poor stream of micturition. There was no history of increased urgency, frequency of urination, incomplete voiding, burning micturition, nocturia. There was
All
no
right.
history of
Yeah.
involuntary
Just tell
leaking
me.
of urine.
Okay, go on.
There was no history of involuntary leaking of urine on coughing, laughing, and straining.
All right. Why is this history important specifically in our case? This history of urination and everything related with it. Why did you say this?
Because in uterovaginal prolapse, there is kinking of urethra, which
Yes.
leads to urinary retention, and it might lead to UTI, leading to all these symptoms like urgency, frequency, incomplete evacuation, burning, micturition, and nocturia, ma'am.
Yeah, these are two very important aspects associated with prolapse. Two very separate and different aspects. Sometimes they can be mixed. The two aspects are either because of the prolapse, she's having such a huge cystocele per se, which is like, making her have some post residual urine. So in that case, what all problems is she going to have if she has post residual urine? Because of the prolapse, because of the laxity of vaginal wall. Anyone can answer, guys. Okay, I'll be very happy if people apart from Nikhil answer, because that is, that means you are also equally prepared and you don't have to prepare separately for prolapse. Half the answers you're giving in the class only. And that makes you not only gain confidence, but also your memory gets very, very sharp if you're able to answer in the class when I'm asking you the question. And I'll give you time. So my question is very simple. There are two separate aspects when a person is having prolapse uterus. And why are we talking? Because of these symptoms. The moment he said these symptoms, I, as an examiner, would like to talk to him about a couple of things over here just to see his concepts. I'm just judging him here, right? So one thing is, along with prolapse, because of the laxity of vaginal wall, there is a big cystocele, and that means maybe repositioning the prolapse back to void. Otherwise, she'll have a significant amount of post void residual urine. What would that lead to? Guys, come on. Okay, some people are typing. Nikhil can also answer. No problem. Nikhil?
Ma'am, significant post-voidal urine could make the person prone for UTI, ma'am.
Yes. Recurrent UTI. It will cause recurrent UTI, and recurrent UTI will present as urgency, frequency, and everything, which is actually a feature of. Anyone? Urgency, frequency, they're all actual features of one more very important aspect of urinary discomfort. What is that? Anyone can answer. Nikhil, you can also answer. You can write down, guys. You can type it in the chat. So the answer is detrusor overactivity. Okay, but there are two important aspects. I don't know how many of you have seen my urogynecology lectures, but they're very, very clear two aspects: stress urinary incontinence and overactive bladder. Okay, now the overactive bladder is actually to be mentioned after urodynamics. But when I speak about urgency and frequency, the first thing that comes into my mind is either urinary infection or something to do with detrusor activity. And we've got to be very careful when we are having this kind of a symptom of urgency and frequency in a patient who's also having prolapse, because you might do a successful surgery of prolapse and she'll be still left with this problem of urgency and frequency, and it might even exacerbate after your surgery, and then she's going to blame you that what kind of surgery you did. Maybe you put that thing inside, but I'm having a very messy life after surgery because these symptoms have rather exacerbated. Okay, so all these things are very, very important to be mentioned and to be spoken about and to be asked in history. That's one aspect. Okay, the second aspect, like he said, is the kinking of the urethra. It happens when the the vaginal wall gets lax. Sometimes even after childbirth, you have a stress urinary incontinence because the urethra, which is the basic support because of which the the involuntary urge of urination is hindered, is suddenly lost because of the laxity. So that is why this is very important. The moment you utter this history, this question is going to be asked to you. Okay, you can continue.
Shall I continue, ma'am?
Yeah, continue, please.
There was no history of any chronic constipation, no history of painful defecation or manual repositioning the mass while passing stool. No history of backache, dyspareunia, or postcoital bleeding. There was no history of any ulceration or discharge per vaginum.
Okay, so there was no ulcer because it was a recent history, 1.5 years, all right, and she was having also lying down. It used to go inside itself. So not a lot of external exteriorization of the prolapse. All right, please go ahead.
She attained her menarche at the age of 13 years and menopause at the age of 50 years. Her previous cycles it lasted for 3 to 4 days, came after an interval of 28 to 30 days. Cycles were regular and it was a normal flow.
Okay, so that means her previous cycles were all regular. All right. And now the
Yes,
most
ma'am.
important obstetric history. I can still not see your history, Nikhil. I don't know. Is there a lag or something?
Ma'am, I have changed my slides, ma'am.
Okay. So just tell me something positive in your obstetric history, because she's having 5 childbirths. So anything specific about your obstetric history?
Ma'am, all the 5 deliveries were home deliveries. That's a positive point. And
Yes.
she was very young when she delivered her first child. And the other thing was she resumed her activities post delivery very early, ma'am. 15 to 20 days after delivery. After each delivery, she resumed her normal activities. There was no history of any instrumental delivery, prolonged labor, perineal tears, or a delivery of a very big size baby.
So that means there were 2 very important points we don't know. See, the ones the moment you say about home deliveries, we do not know actually
Yes,
anything.
ma'am.
How much fundal pressure was given, how much tearing in the episiotomy, if at all that was given or not. What all did they do to get her delivered? How long was the labor exactly? Because they don't have any documented notes, right? It's just a home guy who comes, so they don't even know how long really the labor went, right? Except for the fact, of course, we know for sure that she did not have an instrumental delivery, and that's for sure. That the baby's weight, you asked?
Yes, ma'am. I asked. She told that they were around 2.5 to 2.6 kgs. All babies,
Right,
ma'am.
most of them. All right. So see, you have to write down your history the way he has written down. Okay, the obstetric history has to be complete, like it's written over here. But the examiner will cut you short and ask you this question which I'm asking you. All right. And she's a postmenopausal female, but she is still currently sexually active. Is a very, very important history that you have to speak either right now or later on, but you have to say that sexually active.